Okay. Excellent. So welcome everyone and good morning. Thank you for joining us on this, what is a beautiful day in Ontario, which could be different across Canada, I know, but I'm hoping that everyone is having as wonderful of a day so far as we are. And hopefully after this, you can get out and enjoy some of the weather. I first wanted to start thanking everyone for participating in today's event, whether or not you were an applicant who sent in a letter of intent. We had 13 teams who submitted through letters of intent this year, which is great. And we had 6 teams that we narrowed it down to just because it makes too long of a day to be able for everyone to present. So thank you to everyone who applied and or is participating today. Thank you to those. It looks like there was some congratulations and break a legs in the comments. So thanks to all the supporters that are here for the students. I think it's going to be a great event, as it always is. This is the 8th competition that we've done. So we've been doing this since 2016. We had the first event that we participated in was in 2015 at Maestro, and they hosted a similar event. And they didn't know whether or not they would continue doing that. So the following year, we took on and followed a similar model to what they were doing and have been doing it ever since. I wanted to take the opportunity to thank the Maestro family because after a couple of years of us doing this, they said, hey, wouldn't it be great if we had some monetary prizes for this? So since then, the Maestro family has supported the prize dollars for this event and the encouragement of students to get involved and participate. And I know that they have been part of this event. So special thanks to them. I did want to share some exciting news. I don't think anyone will pull their teams out because of this news, but we are going to match the dollars this year at the foundation. And so those that are competing today, you'll actually be competing for a first place prize of $2,000, a second place prize of $1,500, and a third place prize of $1,000. So we are doubling those funds, and I hope that inspires you to give even a little bit more and some extra enthusiasm in your presentations today for the judges to make their selection. So yes, I didn't think anyone would oppose. Just a quick couple housekeeping items. Just for those who are presenting, each team has a designated presenter. Please make sure that it's your first and last name that's up as the name on the Zoom page, so I can make you give you the presenting rights. And that will be the person that will be sharing the presentation screen. I ask of that person to please make sure that you close all of the additional windows so you don't have anything else that pops up on your screen when you're sharing it, and just gives for a better internet connection. Everyone's mics will be muted throughout the presentations unless you're the presenting team. And then obviously if you're answering any questions from the judges, then you would come off mute. Same with the judges, they will remain on mute until they are you're completely done your presentation, and then they will go into their question period. The questions are for the judges only. So if you do have questions at the very end, we can maybe connect teams with any questions that people might have, or connect teams afterwards. But just in sake of time, just because everyone does get 8 minutes to present, and then the judges will get 5 minutes to answer or ask questions. So just to allow that time flow to move along quickly. At the 7-minute mark in your presentation, I will hold up a 1-minute warning so that you're aware If you have your own timekeeping as well that you've done, I know that a lot of student teams do that, then that's fine as well. But just so that you're aware that your 1 minute is approaching, there will be a timer that goes off. It will sound something like this. And I will let that go off for a few beeps, just so that that you do hear it. I'll do that both at the end of the presentations as well as the question period for the judges, so that people know to wrap up your answers so that we can move forward to the next team. When I put up the 1 minute mark for the judges to let them know that they have 1 minute remaining in the question period, I will ask that the next team that's coming up, that they please queue up their presentation and get that ready to go. What else? Special thank you to Adriana Ranger, to Dr. Joseph Megacy, and to Dr. Ryan Wang, who are today's judges. I truly could not do this event without Dr. Ranger and Dr. Megacy, who have been so supportive in terms of helping with the letters of intent and looking through those. Dr. Ranger, who helped develop the case for today's topic, and Dr. Megacy and Ranger, who were able to help recruit a third judge for us, and welcoming Dr. Wang around the table as well as a third-year resident, I believe, and all are at London Health Science Centre here in London, Ontario. So thank you so much for everything that you guys do for this competition and making this possible. I could not do it without you, truly. So thank you. For those that maybe came in late, if you could please do a roll call in the chat, just put your name in there just so that we can track who was participating. That would be helpful. So without any further ado, I'd like to pass the mic over to Dr. Megacy, who's going to walk you through just the competition and the expectations of the teams, who will then pass the mic over to Dr. Ranger, who will review the case with you. So Dr. Megacy?
Yeah, can you hear me? Yeah.
Yeah.
Okay. So, Sue's already kind of told you the background to this competition. It's been going on for several years now, and we've always had it based around a case scenario. As you all know, when you're doing research, ultimately the goal is to improve patient care and patient outcome. So we come up with a case, and this year Dr. Ranger mostly came up with the case. It's a pediatric case. Dr. Ranger is a pediatric neurosurgeon. I'm an adult neurosurgeon. What you guys did was you got the case, then you sent us the letters of intent, which we reviewed, and then now you're going to give us a presentation based on what you provided in your letter of intent. We all have access, obviously, to your letter and the information there, and we'll listen closely to your presentation and ask questions as appropriate. And then, based on your letters of intent, your presentation, and the way you answer your questions, we'll come up with a 1, 2, 3. But just to let you know, you're all successful. You've gotten through the first round. You've been chosen, and now you just have to give us your best presentation. I'd just like to acknowledge again Dr. Ryan Wang, who is doing this judging at the last moment. Ryan's one of our better neurosurgery residents. They're all good, but Ryan's one of the better ones, and I believe has an interest in neuro-oncology, at least right now. Ryan recently presented last week a presentation at the European Neuro-Oncology meeting in the Netherlands on the banking of brain tumor tissue, using our brain tumor tissue bank here in London as a model. And just for you all to know, the Brain Tumor Tissue Bank in London has been funded in the past by the Brain Tumor Foundation of Canada. Finally, I'd like to acknowledge the Del Maestro family. Pam and Rolly Del Maestro were two of the co-founders of the Brain Tumor Foundation of Canada. And as Sue has said, they continue to provide both monetary support as well as intellectual support. So I'll turn it over to Dr. Ranger to review the case for you again, and then we'll move on. Adriana.
Thank you, Dr. Megacy. I'm just going to try to share my screen here for you. Participant screen sharing disabled. Oh, I'd like to be able to put up the case if I can. I don't know if Jordan is able to help us with that from a...
You should be all set now, Adriana.
Really? Okay. Yeah, case study.
Yep. Thank you.
Okay. So good morning, everyone. It's a real pleasure to be here this morning with all of you to hear some great innovative ideas for research from all of you from across the country. And before getting started, I also just wanted to take a moment to thank Susan Ripers. Thank you, Sue, for all of the hard work and the heavy lifting that goes along with organizing this event, as well as to the Del Maestro family for making this competition possible through their vision for supporting young investigators and also their ongoing financial support with the monetary prizes. It's very nice to be a part of this over the years. So as in previous years, the competition is inspired by a case that's taken from clinical practice. And I'm not sure if there's anyone participating today who's already not familiar with the case, but I will review it now since this was the jump-off point to get the research teams thinking about the problems that we face in caring for people with brain tumors. So this is a patient we know at our center, actually. Jaden isn't his actual name, but his story is summarized here, and it's a very typical presentation of his tumor type. And this is a story neurosurgeons, neuro-oncologists, and our allied health professionals hear with great regularity, unfortunately. And this is a presentation that would be familiar to emergency room physicians, pediatricians, family doctors, nurse practitioners in remote areas, other healthcare providers in primary or emergency clinical settings. This is a very typical example. So Jaden is a 9-year-old boy who was brought to our emergency department by his parents. He had 2 weeks of daily vomiting, blurry vision, headaches, and unsteadiness on his feet. On examination by the emergency doctor, he had gait ataxia, and he had trouble even standing upright without wobbling, as well as double vision. He was investigated with a CT head scan, and that was abnormal, and that was followed up with an MRI scan of the head, and that was done on the same day, which is a bit of a feat at our center, and I suspect other centers across the country. But this revealed a lesion in the 4th ventricle of the brain associated with obstructive hydrocephalus. The neuroradiologist who reviewed his scans favored the lesion to be a medulloblastoma, but couldn't rule out other entities like ependymoma or solid pilocytic astrocytoma. So his family met with our team, and they were provided with the Brain Tumor Foundation of Canada patient handbook about pediatric brain tumors specifically as a resource, and also to help frame some conversation about management options and the next steps that would be undertaken. So he was admitted to the hospital, and he underwent surgery on an urgent basis for resection of his tumor. And during his operation, a frozen section evaluation showed a small round blue cell neoplasm, His finalized pathology was reported a week later, and that confirmed a medulloblastoma, WHO grade 4, classic by histomorphology, and group 4 by subtype analysis using nanostring. His surgeon felt that a total resection was achieved, and his postoperative MRI showed no evidence of residual tumor or hydrocephalus, and he had a lumbar puncture 2 weeks after surgery that showed no evidence of tumor cells. He was discharged at 3 weeks after his operation with a plan to see his oncologist and surgeon for a follow-up visit, and most of the symptoms he presented with had resolved by the time of his discharge home. But he was troubled with a new symptom, however, and that was identified about 3 days after his surgery. And it was characterized by a language disorder, predominantly, difficulty initiating speech, some drooling, and emotional lability. And his parents were concerned that shortly after surgery, he stopped speaking to them and responding to questions just by nodding and shaking his head. And they also observed that he could be calm at one moment and then tearful and very upset quite abruptly without anything obviously having changed with him. And speech therapy was subsequently put in place to help with his new expressive language disturbance. I think there's some imaging here for you. So the imaging was provided to give teams an idea of the typical appearance of this type of tumor. And on various MRI sequences preoperatively as part of the case study shown here. These are very typically large tumors at presentation already, usually located in the hindbrain area of the midline. They measure about 3 to 5 centimeters across typically, and take up some element of gadolinium contrast and show bright diffusion restriction. And that reflects how densely packed the tumor cells are. So you were tasked as research teams to create projects to address a range of issues related to this problem. And I think the teams will know what the potential research problems are, but I think at this point, in the interest of time, we can move to the competition directly.
Thank you so much, Adriana and Joe. I appreciate you taking the time to introduce this. We'll ask that the University of Toronto cues up their presentation, and once that's up, then we will be set to go. Yes, thank you for turning your cameras on. If you have the ability to do so when you're presenting, if each of your team members can turn them on, and then the rest of us will all turn ours off. That would be great. Thank you. So whenever you're set, once you begin, I will start your timer. I will put my camera back on when your 1 minute warning is up, and then we'll ask you to conclude once you hear the timer go off. So ready when you are.
Okay, perfect. And you can see our screen, right?
Yes, we can.
Okay.
Perfect. Thank you so much. Okay. Hello, my name is Nicholas, and joining me are my colleagues Bay, Isha, and Garaza. Today, we will present a proposal for the postoperative treatments aimed at improving the quality of life for pediatric medulloblastoma patients. Cerebral mutism syndrome is a condition that develops following medulloblastoma resection and is reported to occur in up to 50% of pediatric patients following surgical resection, which we believe is the condition that Jaden is suffering from. CMS encompasses a range of symptoms such as ataxia and speech difficulties that may manifest following surgery on the fourth ventricle for pediatric tumors. The prognosis for CMS varies from complete recovery to permanent disability, with some patients experiencing additional emotional instability and decreased cognitive abilities. In regards to previous studies, there is no known effective treatment for CMS itself. While the pathology is not fully understood, the current standard of care focuses on speech, emotion, and cognitive training for rehabilitation. Our goal is to have a better understanding of CMS's neural mechanisms, identify an effective treatment, and establish a reliable procedure for a more confident prognosis. Leading us into our hypothesis, cerebellar mutism syndrome is in pediatric patients post-medulloblastoma resection is primarily caused by damage to the afferent cerebellar tracts, particularly reelin, an extracellular matrix protein, which acts on Purkinje cells in the dentate nucleus, which leads to disrupted neural pathways, resulting in speech difficulties, emotional lability, and ataxia.
An important step in treating CMS is understanding the etiology. Previous literature has established a causal connection between the efferent cerebral tract in the brainstem and CMS. These tracts project onto many areas of the brain, including the temporal lobe, which is important in producing speech. The main modulator of the tract are the Purkinje cells and the dentate nucleus. Hence, we are proposing that the root of CMS may be linked to the dysfunction of these cells. Purkinje cell activity depends on the extracellular matrix protein called reelin, which has downstream pathway activation for dopamine and is responsible for synaptic formation and neuroplasticity. Therefore, the experimental procedures aim to isolate the potential effects of reelin on the development of CMS and the associated brain changes in mice models. The methodology is as follows. One group of mice will undergo a sham surgery and the other will undergo a posterior fossa recession. Next, each group will either be stereotaxically injected with a saline solution or an antibody that encodes for an anti-reelin protein that will then saturate and block the signaling pathway. Brain imaging models such as MRI can be used to observe structural differences between the groups, and an ultrasonic vocalization test will be used to determine a loss of speech. We hypothesize that the mice that have undergone posterior fossa recession and have the anti-reelin antibodies will have statistically significant differences in vocalization and reduced white matter that signify the presence of CMS.
Before I get into our next aim, I just want to read out this excerpt from a 2022 review paper that excellently highlights our current understanding of treatment interventions aimed for CMS. And so it says, at present, no treatment protocol has been established, and the effects of pharmacological interventions are sporadically reported in literature. And that brings us to our next aim, where we want to address this lag. Currently, these interventions include a limited amount of rehabilitation exercises that are aimed at strengthening brain function, cognition, language, and motor movement. However, the rehabilitation approach is strongly limited by its ability to improve patient-specific outcomes. That leads us to our proposal, where we want to move away from the rehabilitation approach and instead test the efficacy of the pharmacological drug bromocriptine in CMS recovery. Some quick background on bromocriptine. It is a synthetic drug that binds to the dopamine D2 receptors and as a result activates the D2 signaling pathway. One of these many effects is promoting neuroplastic growth, which is vital in promoting recovery in a condition such as CMS. Studies have analyzed the efficacy of bromocriptine in treatment following acute brain trauma in rats, and it has shown to increase spatial learning as well as neuronal protection. Moving on to our methodology, following all surgical treatments performed on mice, all groups, including controls, will be administered with bromocriptine stereotaxically near the site of damage. And we can hypothesize that the mice with induced damage to their Purkinje fibers will see an increase in their neural regeneration and synaptic formation.
CMS is common but severe complications. The third aim of study is to establish a predictive model to help physicians to assess the patient status, provide personalized care, and make better clinical decisions. We propose that different models can be integrated to form a virtual brain to mimic the brain activity and to predict outcome on individual level before the operation to prevent CMS. Brain activities can be captured in 3 scales. The microscopic scale is to measure the neurons and synapses. Recently, all principal cerebellar neuron types have been modeled in details, including Purkinje cells. Those models can be used into mesoscopic scales to generate spiking neural networks, an artificial representation of natural local network. Lastly, macroscale models are made of knots and tracts, using tools such as MRI and natural mass models to measure whole brain dynamics. Currently, there are several MRI-based predictive models that carry relatively high accuracy. When they were developed, researchers did MRI for all patients before and after surgery. They compared the result between CMS group and non-CMS group and with their pre-operative performance. However, these procedures have a limitation that they are finding correlation instead of causation. We believe bridging microscales and mesoscale models into macroscale will provide more support and bring promising predictive model. Learning from real-life results and introducing computational programming to process connective data in large neuron population, we expect that building virtual brain model in multi-scales can lead to significant improvement of predicting CMS.
The implication of the study could mean several things. One, an understanding of how CMS develops and what precautions can be taken pre and post surgeries to ensure proper patient care and optimize neuroplastic growth, and also using computational models to predict the severity of CMS and intervene for more successful outcomes. And number two, having a mouse model that can be used to test more effective therapies and further deduce the pathway regarding CMS, as well as other pathologies that interact with the efferent cerebral tract.
Towards the end of our presentation, we'd like to mention a few possible directions for future studies to explore. In particular, we want to emphasize that majority of the efforts should be focused on validating the pathology and the underlying mechanisms that govern CMS. If future studies concentrate approximately 50% of their efforts on understanding the pathology of CMS, then we can move forward and pinpoint the most effective treatments and then build predictive models. One suggestion that we have is to use an AAV virus to track the cerebral pathway and confirm whether Purkinje fibers are located on this track. And then to establish whether treatment is effective, studies can utilize a between-subject treatment design and then test the outcome in solo rehabilitation compared to a combination therapy that involves rehabilitation and a pharmacological drug. And finally, mice studies can be used to obtain relevant data that can help build this multi-scale model that's specific to CMS. It's a long journey ahead, but we're confident that in the coming years, there will be new and important insight into helping these patients that are suffering from cerebral mutism syndrome. In the end, we'd like to thank you all for your time and for the opportunity to present our ideas here today. Thank you so much for having us.
Thank you very much. That was great. Judges, I'll open the floor to you for any questions.
It's Adriana here. Are you able to hear me okay?
Yeah.
Okay. Well, thank you, Nicholas, Isha, Bay, and Garaza for a really nice presentation. I thought for starters that it was very well organized, clear, and a pretty logical premise, actually. And thank you also for being the first team up and just being ready with your nice presentation. You must feel a bit relieved, I hope, I imagine. My question for you relates to not so much the idea of using bromocriptine as a D2 receptor agonist, but really the concept of stereotactic injection and what would your target be and why would you choose that target as opposed to maybe giving something systemically. And I can understand why you might want to avoid off-target effects. And maybe that's why you're thinking stereotactic approach. But what would your target be specifically?
I think in general, it would be the area where we've induced the damage. I'm not so sure where in particular that would be. But as you mentioned, the reason why we want to do a stereotaxic injection is because of its specific location. And when bromocriptine under normal circumstances, as it's used to treat Parkinson's disease, I'm fairly sure that it's taken as an oral drug. However, in this situation, because we want to see the immediate effect, we felt that an oral injection won't be as specific as, for example, a stereotactic injection directly where we've induced the damage in the brain.
Do you pause it because stereotaxy is so precise? I mean, are you thinking that you would introduce it in a sort of in a peri-resection region? Could you postulate a site maybe?
Well, since the damage or where we're inducing the damage is the posterior region of the brain, I'm not sure too specific, I don't know particularly the exact regions of the brain, but I would assume that, and I would hope that it would be in the posterior region of the brain where that's being injected. I hope that answers your question.
Adding on to what Graza said, as you mentioned in the beginning, it would definitely be near the cerebellum, the brainstem, because that's where the dentine nucleus is mostly located. So we're hoping to specifically target the brainstem area.
So I have a question about just the model. I think we all know that we're going to translate research from a model to humans. we want to have a good model. Have you guys looked at the mouse brain? Does it have a similar components to the human brain? I assume it does. It might even have a bigger cerebellum than the human brain relative to the cerebrum, but have you guys looked at that? And the other question I have related to that is, what is the vocalization exam? Something about ultrasound. I mean, I think we might have a mouse in our garage, and I've never actually heard a mouse vocalize. The expression "quiet as a mouse." So do they make noises, and how are you going to test that?
For the first question you are asking, is that I do find some interesting paper about their making mesoscales model on mice brain. I'm not sure if that answers your question completely. Is that there's previous studies that do have similar experience or their study on that, but we're more focused on making multiple scales. So this is like, I understand there's some, different differences between human brains and mice brain, but I believe if it's achieved on mice brain, it for some degree can help us to translate them from the animal model to human models. And sorry, what's the second question?
The vocalization. How do you determine if a mouse is mute?
So essentially with ultrasonic, the vocalization test, the frequencies are ultrasonic. So to the human ear, we are not able to hear it. However, the specific machinery they elicit specific responses like stress situations. And so the mice will release their frequency and that only other mice can hear. But since we have the technology, we are able to understand those frequencies and record them.
No wonder I can't catch the mouse in the garage. Anyway, back to you, Ryan. Question.
Hey, can you guys hear me? Perfect. Yeah, great presentation, guys. Enjoyed hearing that and also seeing how organized your presentation was. Do you guys know if there are any models for monkeys potentially with Medulo? Because that would be an interesting thing to think about. That might be maybe potentially more translatable from a mouse perspective, but I don't know if have you guys heard of anything, or I certainly haven't.
Well, I noticed there's a model for monkey. Well, it's not really a model, but it's trying to detect the neuron or the synapse activities from monkey's brain. But I haven't really heard if they're building a model yet. But that paper actually showed that it's possible, or we have a way to do that. So I think it's leading us to like the place we want to be, but we just need more time to figure out how things gonna be working. Hope that answered your question.
Thank you so much, everybody. That is the conclusion of the question period for this team. Thank you so much for your time. And we have now got McMaster that is queuing up their presentation, and I will hit start whenever you guys are ready to go.
Are you ready? Can you guys see me?
Hi everyone, my name is Kevin. I'm here with my colleagues Wenjin, Jonathan, and Wasam, and we're from McMaster University, and we're going to be presenting to you our proposed musical intervention using melodic intonation therapy and intergenerational drum circles for improving quality of life and speech-language pathology for those diagnosed with medulloblastoma.
So here's a quick roadmap of our presentation, and we'll start with an intro, proposal, methodologies, analysis, and then expected results. So medulloblastoma is a brain cancer that accounts for nearly 10% of all childhood brain tumors and occurs exclusively in the posterior fossa. Medulloblastoma is also categorized as a grade 4 tumor, meaning that it is very aggressive and very malignant. Furthermore, the subtypes for this cancer include WNT, SHH, and non-WNT and non-SHH. Treatment of medulloblastoma involves a resection of the medulloblastoma tumor. However, this can lead to ataxia dysarthria, which is a condition caused by damage to the cerebellum. And patients with this condition will have difficulty in speaking, such as slurred speech, difficulty starting sentences, and difficulty pronouncing consonants. In order to treat ataxia, music therapy can be used. Furthermore, emotional lability and difficulty initiating speech that was observed in the case study subject can also be treated with music therapy. As such, we can use melodic intonation therapy in particular, which can be used to treat ataxia dysarthria and involves the use of melodic intonation and rhythm to help restore language and is promising for treating language disorders. An intergenerational component can also be incorporated, and individuals of multiple generations participating in the therapy together.
So moving on, our research program is to evaluate the impact of both MIT and the intergenerational drumming circle on speech-language pathology after a medulloblastoma tumor resection. And so moving on to our rationale. So we're trying to address the long-term neuromotor speech outcomes of medulloblastoma. And as such, we've identified the major areas of concern as being communication skills, speech motor skills, and psychological and emotional well-being. And thus, we'll be using MIT to improve speech abilities. And while MIT is usually used to address the symptoms of aphasia, we've decided to keep important and useful parts of MIT, such as its ability to regularize speech rhythm, as a way to better address the symptoms of medulloblastoma. And additionally, we'll be using intergenerational drumming circle to target psychological and emotional well-being in the patients as well. And so our hypothesis is that the use of MIT in conjunction with the intergenerational drumming circles will improve patient well-being and communication as measured by the quality of life scale and the quantitative analysis of interviews. And so for our specific aims, first, we would like to improve speech and communication skills for the use of MIT, and we'll also like to improve QoLS score by integrating MIT and the drumming circles into standard treatment modalities.
So in terms of our populations of study, we're going to be including older adults, which consists of community members ages 65 and above, specifically 5 of them, 1 music therapist that would lead the sessions, and 5 children, which are patients ages 5 to 17 with a who have undergone medulloblastoma resection. And that's because medulloblastoma is more common in the pediatric population, specifically, I believe, around the ages of 1 to 9, but we wanted a more developed age group. So we chose the age range 5 to 17. And in terms of our overall methodology, the actual intervention consists of bi-weekly hour-long sessions led by the music therapist, the group sessions, in addition with the 30-minute MIT sessions. The drum circle will utilize djembe, which is a commonly used drum circle instrument, which each participant will have access to. And we will begin with a 30-30-30 structure in the first third of the intervention, where participants will engage in 30 minutes of individualized MIT, as well as 30 minutes of music activities and 30 minutes of non-music activities, and then transitioning to a 30, 45, and 15 structure in the last 2/3 of the intervention, where they engaged in 30 minutes of MIT, 45 minutes of music activity, and 15 minutes of non-music activity.
Perfect. So just as a primer before the actual MIT itself, we've included breathing exercises because this is typically used for ataxia dysarthria treatment. So what's going to be happening is we're going to use these breathing exercises to ensure that patients have enough breath support to be able to coordinate respiratory, phonatory, and articulatory systems in order to ensure that they can vocalize properly. Initially, the non-speech breathing will target slow to moderately paced abdominal and ribcage expansion during inspiration and relaxed expiration. This is going to move from supine to seating to finally standing position. Then movements are going to progress from walking in place to treadmill walking, then free walking, and there are going to be speech breathing tasks here as well that are going to essentially target behaviors with the additional goal of inspiration followed by, or fast inspiration followed by controlled expiration with vocalization. Right. Perfect. And then moving on to the MIT itself. So as Wenjun was kind of talking about, MIT, next slide. As Wenjun was talking about as well, the MIT is really focused on using the melody and rhythm inherent in music and making it progressively harder for the patient to help them vocalize. So we're going to start in the beginning with simple unison intoning, which is essentially the instructor is going to be tapping with the patient and singing along with them. as you can see with the phrases there, the target phrases. And then they're going to be fading out. Then in the intermediate part, there's not going to be any initial unison intoning. We're going to go straight to the fading. And then finally, in the advanced part, we're going to introduce something called Sprechgesang, where they're essentially fading out halfway. So we're going to make it progressively harder for the patients to make sure that they're improving and that vocalization is improving as well. Perfect. And now, in addition, we're going to be allowing at the discretion of the instructor or the therapist to include any exercises or modalities that they think are appropriate as well. So for example, that might include breathing via breath control. It might also include prosody via sentence stretch and heteronyms. And it may also include LSVT and speak out, which is typically used for Parkinson's patients, but may also be appropriate with ataxia, which is basically just helping them with the quality of their voice, so the loudness, as well as the quality and register with the speak out. Awesome. So now when we're talking about our methodology, there's going to be two components: quantitative analysis, where we're going to be using the quality of life score based on these 5 domains that have been identified. And that's going to be just a score. And there's 16 questions on a scale of 1 to 7 or 0 to 7. And then as well as qualitative analysis, basically trying to explain those results in more depth. Awesome. So for the quantitative analysis, patients will be completing the quality of life score prior to their first interview and every month following. We're going to be using ANOVA and post-hoc analysis in order to see the significance there. Then when we're talking about qualitative analysis, there's going to be interviews conducted every 4 months according to the categories that we described, and the results are going to be thematically analyzed using in vivo.
So here are just some examples from our protocol that we came up with for our interview. For example, we might ask questions like, how satisfied are you with your number and quality of your friendships, to kind of guide the interview. And then we would then identify themes such as the reason for the patients participating in the program, and then identify codes from those themes such as having an interest in creating music or dissatisfaction with their current quality of life.
Yep, and just when we're talking about expected results a little bit more, the semi-structured interviews should show positive outcomes associated with each of the 5 domains, and the quantitative analysis should reveal a statistically significant difference, which we've kind of shown here with a p-value that's meets the threshold, and so we can reject the null hypothesis and conclude that there was a statistically significant relationship.
So in summary, we'll be essentially integrating MIT and drumming circles into the current treatment plans for a patient with medulloblastoma, with the overall aim of improving speech, communication abilities, and overall quality of life.
Perfect. Awesome. Thank you. Thank you so much for listening. And here are our references. And again, we want to show our appreciation to the Brain Tumor Foundation for giving us this opportunity.
Thank you very much. I'll now open the floor to the judges.
Okay, I just have more of a methodology question. From your presentation and from your letter of intent, it says the populations that will participate in this study consists of an older adult community members, those age 65 or older, and children who have been diagnosed with medulloblastoma, ages 5 to 17. Only the pediatric population will be studied. I'm a bit confused. So what is the role of the older adult community members?
So typically how studies with intergenerational components have worked in the past is they have the 2 different generations, but it's better for the overall study itself to focus on one population of interest rather than multiple populations. And so in the past, studies have shown that the intergenerational component actually does improve emotional and physiological enhancements and more positive effects both prior to, during, and after the program interventions. And also it creates a sense of community, which can help in improving the quality of life of the participants.
So just, I must be obtuse or something, but so you do study this older population?
No, so we're only investigating the children involved.
Okay.
Yeah.
Thank you.
Let's see. Hi there. It's Adriana here. So yeah, I just want to congratulate you on this research idea. Have any of you encountered any individuals with this type of problem? You're in the health sciences program at McMaster. I don't know if you've ever met anyone with a pretty bad cerebellar dysarthria.
We personally haven't seen anyone, although we can imagine how difficult it must be and all of the struggles that would be going on in such situations.
Yeah, it's really distressing. And so it's nice to see this kind of approach to tackling this problem, because for families not being able to communicate with their children and vice versa, it is a really big deal. So I do think that it's a really great quality of life initiative. On slide 11, you were talking about some postural aspects of breathing exercises, and I think that you would have to maybe modify some of your protocol, because some of the kids who have bad cerebellar mutism, although this case study, the patient was able to improve their gait ataxia, a lot of them can't even get out of bed, for one. So that might be a bit of an obstacle. And the other thing that I wondered was just about the quality of life questionnaire and the younger children. Like, who are you going to be collecting the questionnaire data from? Or you might have to select a quality of life questionnaire that's appropriate to the age demographic, because a 5-year-old and a 17-year-old may not be able to answer your questions in a similar way. So I think you'd have to consider that. I guess it's not really a question, but more a comment, or if you've considered that aspect of things, because your age range is quite broad. And the question I had was just sort of the cost of implementing this project, because to me it seems very doable, and it may be a cost-effective sort of thing. I mean, have you thought about a budget? It's not part of the research question, but have you thought about a budget or how implementable it would be?
Yeah, for sure. That is something that we've considered. We don't think it will be particularly expensive, because a lot of the benefit that comes from this is more the community aspect of it, and that's not necessarily something that's a monetary value, right? So in terms of the Djembe, that the overhead cost should not be that expensive, and we see that in the case study currently, the patient is already paying to go see like a speech therapist, right? But this speech therapist is not necessarily including the aspects or the modalities of intergenerational, nor is it using MIT. So that we feel that won't be super expensive to implement. Going back to your question on the breathing exercises in particular, that is something we included, but it's going to be used at the discretion of the speech of the therapist. If they find that the patient literally cannot get up or can only lie down, that they might adjust accordingly. These were just different modalities that we added in that are can be used and should be used in addition to MIT to make this more applicable for ataxia dysarthria in particular.
Thank you.
Brian, do you have a quickie?
No, and I don't have a question, but great presentation, guys. Thank you.
Is the next group starting soon?
Oh, okay. I can start. Yeah, that's fine. Hello, my name is Sausan Hayder, and these are my colleagues Ali Hayder and Anhad Law. We wanted to thank the Brain Tumor Foundation of Canada and the Del Maestro family for giving us the opportunity to present today. So we will be discussing how we can use machine learning analysis of MRIs to predict molecular subgroups of medulloblastoma. So as you know, medulloblastoma, or MB, is a cancerous tumor which begins in the cerebellum of the brain. MB develops as a result of mutations in certain genes. Depending on the genes impacted and the biochemical signaling pathways that are altered, MB can manifest as one of 4 molecular subgroups, each with different tumor tissue composition, as well as different prognosis rates. These 4 groups are wingless, or WNT, sonic hedgehog, or SHH, group 4, and group 3 MB, ranked here in terms of prognosis from most favorable to least favorable. So why is it so important to be able to identify a patient subgroup? Research suggests that identifying subgroups is crucial for the personalization of treatment, the prediction of outcomes, and the improvement of disease management. For example, the extent of tumor removal during surgery may not uniformly affect survival across all 4 molecular subgroups. Thompson et al., for instance, found that tumor removal during surgery does not significantly affect survival in WNT, SHH, or group 3 MB, but it does improve survival in group 4 MB. This is important because surgeries carry inherent risks, which we had seen in the case study with Jaden's postoperative symptoms. So identifying a patient subgroup can help us to determine the optimal extent of surgical tumor removal and can therefore minimize undue complications. What we are hypothesizing is that we can use a machine learning model to predict the molecular subgroups of MB using radiomic analysis of MRIs. The aims of our study are twofold. First, to create a machine learning model which allows for faster and more accurate medulloblastoma subtype classification relative to the status quo, which at this point are biopsies and histological analyses. And second, to empower this machine learning tool to investigate patterns between and within subgroups, thereby fostering a deeper understanding of these subgroups and potentially identifying subtypes within them.
It's important to understand the different aspects of machine learning which you may not be familiar with. So AI is a machine's capability to imitate the cognitive abilities of humans, within which there are a number of subdivisions, of which ML machine learning is one. ML is a field in which computers can learn automatically from data. These systems are effective as they can follow rules, but can also improve with experience after assessing large amounts of data. These rules can also be known as ground truths. The incorporation of ground truths mean that machine learning occurs with human verification. The ground truth is a human radiologist baseline with which the machine's performance is verified. With this, the algorithm can consistently improve until it becomes effective. The interconnections of multiple layers of algorithms come together to create artificial neural networks. CNNs are convoluted neural networks that are a subtype which focus on image classification such as MRIs. Now, as mentioned, these CNNs must be trained by ground truths. Here, a ground truth experienced team of radiologists would manually draw a region of interest over MRI images collected from the patient dataset. The patient's dataset should come from multiple centers, and there must be a diverse patient population, each with different MB subgroups. From these MRIs, radiomic features are extracted, transforming these images into quantifiable data understandable to the CNN. For example, the grade level co-occurrence matrix is a technique which extracts texture-related information based on the spatial relationship between pixel intensity values. Here, the ML model learns to associate distinct radiomic feature patterns with each subgroup. Once the ML model is trained, the CNNs are tested with validation datasets, assessing the accuracy of the algorithm. However, during the process of validating the CNNs, care must be taken to avoid what's known as overfitting. Overfitting is when the CNNs can learn the irregularity of the datasets instead of accurately identifying general trends in data. So to avoid this, we'll incorporate at least 100 plus patients with different subgroups of MB from various clinical centers. Other validation schemes will be used to test the performance of the ML model. Firstly, we'll perform a double 10-fold cross-validation with the datasets. This involves dividing the data into 10 parts, training the algorithm from 9 parts, while testing the now trained algorithm on the remaining part of the data. This process would then be repeated 10 times, testing the model on a new part of the sample each time. Now that the ML model has been trained, we'll ensure there's no between-center error by cross-validating the algorithm on an independent dataset from a different institution. Finally, using a Wilcoxon rank sum test and a classifier, we will identify differences between the models. After this training and validation, the model is ready to be used in conjunction with radiologists.
As Anhad mentioned, the ML model uses radiomic features to predict the subgroups of medulloblastoma. Radiomic features refer to the extraction of a large number of patterns and characteristics that exist between the subgroups. In artificial intelligence, this is known as data characterization. The model works to determine radiophenotypes, described as subgroups, that are present based on repeated trends of the radiomic features it sees in the ground truth MRIs. Some examples of the radiomic features that the model will assess include tumor edge sharpness and post-contrast enhancement. Tumor edge sharpness in specific shows when and where in relation to surrounding areas of pixels a tumor starts and ends on an MRI. Post-contrast enhancement is the change in signal following the addition of contrast. These are examples of key aspects of MRIs radiologists use which can be applied to our model quantifiably. This can help to reduce the number of biopsies that are performed to determine the medulloblastoma subgroup. This limits the risk of surgical flaws that can occur with medulloblastoma patients and potentially increases accuracy in comparison to only using radiologists. In terms of the framework of this machine learning model, we determined that the model needs to extract 590 key radiomic features. This was concluded based on several studies using 10-fold validation strategies, which indicated that 590 radiomic features produced the highest area under the curve, meaning the most accurate results. These studies involved both T1 and T2 weighted imaging, which enhanced water and fat content respectively. The results showed high success of recognizing sonic hedgehog and group 4 images of medulloblastoma. However, the studies didn't show much success in identifying WNT and group 3 images of medulloblastoma. To combat this issue, we plan to use other MRI formats, mainly diffusion-weighted imaging, which contrasts Brownian movement. These types of MRIs are able to recognize different radiomic features more effectively that can be used to better differentiate and recognize both WNT and group 3 medulloblastoma. The ML model has the potential for even more specialized use in terms of pattern recognition. Recent research has shown that within each of the subgroups, different subtypes also exist. These subtypes have not yet been formally recognized and named. However, we hope that our ML model can be adapted to recognize the key radiomic differences that make up these subtypes. This will allow for even more patient-personalized treatment based on the subtype identified within the subgroup. It also allows for more research into unique gene mutations based on the subtype identified within the subgroup. The heterogeneity within each group, characterized by different radiomic features identified by the ML model, could also inform clinicians about how to improve surgical resections and chemo or radiotherapy. Overall, we hope that our model can help us enter an era in which treatment decisions are anchored in the intimate understanding of a patient's unique tumor biology. Thank you for your time.
I don't know, Ryan, do you want to start?
Yeah, sure, I can. Great presentation, guys. So I have, I think, two quick questions. One, I know you're using imaging to kind of correlate between which subgroup these tumors are in. Are you cross checking this with the actual pathology of the tumor? Because, I think for us, from a surgical side, really the definitive diagnosis is from the tumor pathology. We use the imaging to help plan surgery and give us an idea, like a differential diagnosis, but we don't heavily rely on that. And then the second point is maybe just more of a for me for learning because I'm not a machine learning expert at all. But how does AUC correlate with like sensitivity and specificity of the test?
I can take on that first question, but yeah, we would be cross-referencing it with the actual pathology. So all the MRIs that we do get, we would know exactly what group they're in just based on either nanostring or some other type of sort of just confirming it based on the histology and that sort of stuff. And then I think I can pass it on to Anhad for the machine learning question.
Actually, I think Ali with the area of the curve can answer that better here.
For sure. So the area under the curve was really part of a lot of different studies that looked at how the different types of imaging can produce the highest yield results. So in terms of specificity, it was really specific to the different types of images. And then based on that, the ones that produce the highest area under the curve were applied to the specific subgroups that we're looking at.
Okay, thank you very much.
Go ahead, Adriana, if you have some questions.
Let's see. Okay. Yeah, thank you for your presentation, Ali, Sausan, and Anhad. I really enjoyed it. I have to say, I find it really challenging to look at imaging. I think clinicians do, neurosurgeons, neuroradiologists. We look at these every day, and we even guess at what a differential diagnosis might be when a tumor is discovered across many possibilities. So I find it astonishing that you could use machine learning of some kind or a convoluted neural network to even subtype something right at the point of diagnosis radiologically. Sometimes we have difficulty telling, is this a medulloblastoma or is this an ependymoma? And ependymomas have subtypes too. So I find all of this is really quite exciting. I wonder if CNNs are eventually going to replace radiologists or pathologists eventually. Do you think so?
I can take this one. I personally don't think so at the moment. As you mentioned, it's really hard to make a diagnosis, even like differential diagnoses, and then it's even harder to narrow it down to the subtype. as you mentioned, right now, like CNNs and AI in general is at like more of a starting point. And like, as I mentioned, the machine learning model like learns as it goes and as it's fed more data. At the moment, we haven't like taken too much initiative into this like avenue of research, but as like AI grows, we will be able to see the possibilities and like the limitations of AI. Like right now, it's really in the early stages. And once like AI, the CNNs begin to learn and are fed this data, then we can like get a better sense of like where this is going in general. But in terms of like whether this will replace like radiologists or not, as I mentioned, it's essential we have like human verification, because these things are so complex and it's not something that like is based off of one image. Again, how we mentioned earlier, has to also go into the pathology and the histological aspects of it as well. So the ground truths must come from human radiologists. So basically the whole basis of the ML model is from humans. So I don't think like they'll be getting replaced anytime soon.
I see. Well, thank you. And it seems, as I was reading through your letter of intent, which I thought was well written, clear, very logical, and also a little bit mind-blowing, you know, like how could you even get to a subtype on imaging? You know, this could be applicable to any MRI then, because it looks like you're using some pretty basic sequences that we look at all the time.
Yeah, that's definitely the goal, I think, to be able to expand it, not just like in neuroimaging, but we looked at some studies that had tried to identify tumors in the lung, and you can really expand it to a lot of different disciplines, which is what makes it so exciting.
Okay, thank you.
I think that's it, Sue, right?
Sorry, yes, I was just saying, Joe, you had 5 seconds and I was muted. Oh my goodness. There we go. Excellent. Thank you so much for your presentation. That was great. We now have University of Calgary. So whenever you're all set, if you could begin, please.
Hi, my name is Dima Al-Rufai.
And my name is Amna Idris.
And we'll be presenting the molecular targeting of group 4 medulloblastoma with ultrasound-mediated microbubbles to mitigate post-operative cerebral mutism risk. So let's dive into some key facts about medulloblastoma. It ranks among the most frequently diagnosed pediatric tumors and manifests as a solid mass in the cerebellum. Medulloblastoma is further characterized by 4 distinct types: Wnt, SHH, group 3, and group 4. It constitutes about 20% of all childhood cancers. Its 5-year survival rate is 72%. And lastly, 35% of medulloblastomas fall into the group 4 category. Taking a look at Jaden's journey, it all began with the emergence of his symptoms like nausea and persistent headaches, which prompted a medical investigation that included an MRI scan. The diagnosis revealed the presence of group 4 medulloblastoma. Jaden's treatment started with a tumor resection and was monitored by his medical team. However, as time went on, Jaden began experiencing new symptoms, which included speech difficulties, abnormal fluctuations in mood, and drooling. And our research will be dedicated to addressing the treatment of medulloblastoma with the aim of reducing the risk of experiencing these symptoms. These symptoms are part of a post-operative condition known as cerebral mutism syndrome or posterior fossa syndrome. The syndrome is characterized by mutism, ataxia, and emotional lability. Children like Jaden who experience CMS face potential long-term impact on their quality of life. So far, there's no standard pre-operative treatment to mitigate the risk of CMS in medulloblastoma patients. Our research objectives center around enhancing the standard treatment for large group 4 medulloblastoma tumors and improving the quality of life after tumor resection. Our hypothesis is by reducing the size of larger tumors, we can reduce the risk of post-operative CMS. Our approach involves drug delivery using ultrasound-mediated microbubbles to precisely target group 4 medulloblastoma at a molecular level. We will concentrate on 3 key characteristics of group 4 medulloblastoma in our research, and this will be the intact blood-brain barrier, the distinctive BMI1 high and low CHD7 protein ratio, and the increased presence of ERBB4 SRC signaling compared to other medulloblastoma types, which signify downstream activation of the MAPK and ERK pathways.
BMI1 is a protein of the polycomb repressive complex, or PRC1, which functions through epigenetic repression by histone ubiquination of histone 2A. Through this function, BMI1 is involved in the pathology of group 4 medulloblastoma in 2 critical ways. 1, the activation of the MAPK pathway through the repression of the ERK inhibitor DUSP4 to thus increase proliferation. And 2, the repression of the bone morphogenetic protein 2, or BMP2, to decrease apoptosis, as you can see in the picture on the right, where BMI1 represses the downstream receptor, ID1, of the BMP2 pathway.
The BMP pathway plays an important role in inducing apoptosis in medulloblastoma cells, but as previously mentioned, the elevated levels of BMI1 protein inhibit this pathway. Additionally, increased presence of phosphorylated ERK1 and 2 further drives cell proliferation, resulting in uncontrolled tumor growth. It's important to note that medulloblastoma tumors larger than 5 centimeters significantly increase the risk of surgical complications that could lead to CMS.
Microbubbles are inert gas bubbles in a shell made of elastic material, usually lipid, albumin, or protein. They're administered into the bloodstream, and with exposure to focused ultrasound waves, these microbubbles will expand and contract, exerting pressure on the capillary walls of the blood-brain barrier, resulting in the opening of tight junctions and allowing for transient paracellular transport, which can last up to 24 hours. Using the microbubbles in conjunction with focused ultrasound allows for targeted delivery of drugs to brain tissue while maintaining the blood-brain barrier due to the transient nature of the opening. This presents a safe and non-invasive approach for spatially localized drug administration. So what is focused ultrasound? This is a type of ultrasound which converges the sound waves in phase into a focused beam, allowing for this controlled and targeted delivery when used with contrasting agents like microbubbles. Now, there are 2 types of focused ultrasound, high and low intensity. We propose to use a low intensity focused ultrasound as it has the advantage of non-thermal effects, which allow its ability to be delivered deep into the brain without causing permanent damage. Our proposed mechanism is to combat the effects of BMI1 using 2 inhibitors, PTC209 and PD325901. PTC is a small BMI molecule inhibitor, and PD is a mitogen-activated ERK kinase or MEK inhibitor, which blocks ERK1 and 2 phosphorylation in the pathway. We propose to administer both inhibitors with conjunction with microbubbles into the bloodstream. Focused ultrasound will then be applied to transiently open the blood-brain barrier, allowing for paracellular transport of the drugs into the cerebellum tissue. The inhibitors will then function to inhibit BMI1, thus repressing ERK1 and 2 phosphorylation and the subsequent MAPK pathway, along with relieving the repression on the BMP2 pathway and allowing for apoptosis. The result is apoptosis of these BMI1 high and CHD7 low cells and reduced proliferation of these cells. Our specific aims are 1, to assess the feasibility of this targeted drug delivery system, 2, to assess the impact of the targeted drug delivery system on tumor size reduction of group 4 medulloblastoma, and 3, to assess the effect of BMI1 and MAPK inhibition on the incidence and severity of post-operative CMS in group 4 patients. For specific aim 1, we propose an experimental design using a rodent model in which there will be 3 treatment groups. The first group will be a control group that will be delivered microbubbles with a saline solution. The first treatment group will be delivered just the inhibitors without the focused ultrasound-mediated microbubbles, and the third group will be administered both the inhibitors along with the focused ultrasound-mediated microbubbles. Using Western blot, we can assess the feasibility of focused ultrasound-mediated microbubble delivery of the inhibitors. We expect the delivery of the inhibitors using this focused ultrasound mediation to be more targeted and efficient. Thus, treatment 2 should show a greater decrease in both phosphorylated ERK1 and 2 and a decrease in BMI protein levels in comparison with treatment 1. For specific aim 2, we expect the control group to show no decrease in tumor size, treatment 1 to show an intermediate reduction in tumor size, and treatment 2, the delivery of the inhibitors along with the focused ultrasound mediated microbubbles to show the greatest reduction in tumor size.
For specific aim 3, a clinical trial will be conducted. The treatment group will receive the FUS-mediated microbubble delivery of the inhibitors prior to their scheduled surgical resection. Thorough post-operative monitoring of the patients will be conducted to gather data on the incidence and severity of CMS. The data will then undergo analysis for comparison with the control group. And the control group in this context will be hospital records of patients with similar diagnoses who underwent surgical resection without this treatment. Our main contribution is an innovative approach for a targeted and minimally invasive treatment for medulloblastoma. For mitigating CMS. This treatment will result in an increased quality of life and a decrease of long-term neuropsychological deficits for pediatric patients after the resection. These are our references, and thank you for your time. Any questions?
So I can start questions. I think, can you hear me?
Yes.
Yes, okay, I'll start the questions. I guess the first question that I would have is, based on what you've read or the literature that you've reviewed, how long would you think the treatment that you're proposing would take to shrink the tumor? Are we talking hours or days or months?
Yeah, I'll be happy to answer that. So in past treatments where they've used sort of this pre-operative ultrasound on different types of cancers, usually the chemotherapy could last for like, I guess with the specifically for focused ultrasound, each sonication round will last for about 20 to 30 minutes. And again, it will be specific to every patient as they'll have different tolerance and different reactions to it. And this will be done, I guess, it can be effective even from one cycle. Of course, as you increase the number of cycles, it'll be more effective. And for our treatment specifically, we're looking at maybe about 3 cycles in order to have the greatest effect. And at the same time, not delay the surgery for such a long time. So we're sort of looking at a middle ground for the most number of cycles for it to be effective in a shorter amount of time.
That's very nice, but are we talking hours, minutes, days, weeks?
Like for the actual sonication period?
No, for the tumor to shrink.
For the tumor to shrink, yeah, it can happen in a number of weeks. So it can happen in a few as 3 weeks. Yeah.
So that's the issue here. I mean, the case that you were given, Jaden, that is a very large tumor.
Yeah.
And that patient could not wait weeks for their surgery, or should not wait weeks for their surgery.
Yeah, definitely. I think for larger tumors.
Having said that,
oh yeah,
I think your goal of your surgery is to minimize the chance of cerebellar mutism. What I see as more intriguing, to me at least, is what about using it after the tumor's been removed? Let's say the patient has the tumor removed, doesn't get cerebellar mutism, they don't always get it. Could you not use your treatment to go after any residual tumor which the patient might have?
Yeah, and that's actually, yeah, Amna, you can go ahead.
Yes, I was going to say, so focused ultrasound is actually up and coming in many different research fields. So for pre-operative and post-operative chemotherapy administration, but we are focusing for, as you said, larger tumor sizes, which are a priority for surgery, but also have a great risk for cerebral mutism, as we said. So greater than 5 centimeters have a high risk of developing the cerebral mutism syndrome. So they will be prioritized, I guess, in treatment of focused ultrasound pre-operative administration of drugs.
Yeah, and definitely not over large tumors that need urgent surgery, and more tumors that are closer to that larger range of tumor size.
Thank you.
Thank you.
Yes, Dr. Maxey, that was the first question that came to my mind too. I would love anything that makes a tumor smaller to operate on. But, I think that there would be a lag time that would not be acceptable, depending on the presentation of the patient. But at recurrence, I think that this could be a great idea. And I imagine that this could be applicable to a range of therapies like delivery of CAR T cells to a tumor, or immune checkpoint agents, or nanoparticles carrying chemotherapeutic agents. So it's another way of the problem of opening the blood-brain barrier, which has been around for quite a while. There are different ways to tackle that and get around the privilege the brain has and avoiding its treatment. But yes, I think there'd be a bit of a lag time. I think what happens to the bubbles after? They just break down?
Yes, so they are inert. So once they oscillate and they do break apart, they don't cause any off-target effects because they are made of inert gas bubbles. So they do break down, and then the subsequent delivery of the drug through the blood-brain barrier.
Yeah, and what's special about it is that it's a very transient opening of the blood-brain barrier, and it can close even as soon as 24 hours after opening.
Ryan, any questions for me?
You actually just answered my question. I was going to ask how long does it actually stay open for, and you answered it. So thank you.
Yeah, of course.
Excellent. Thank you very much.
Thank you.
It looks like that Sherbrooke is all queued up. So whenever you're set to begin, please do.
All right, so can you hear us, please?
We can. Thank you.
So hi, everyone. Hope you're doing well. My name is Widad. I'm with my colleagues, Jasmine Michel and Cédric Marchildon, and we are glad to share with you our research proposal about the effects of radiotherapy in medulloblastoma on volumes of cortical areas and cerebellum and thickness of subcortical areas. Our study is an AI-assisted study. So before going forward, we want to thank the Pam and Rolando del Maestro family and also the Brain Tumor Foundation of Canada for this opportunity, and also excuse our bad English. So let's begin with some background, a word about the WHO classification. It allows for the molecular distinction of medulloblastoma, with some being more aggressive than others. In Jaden's case, we were talking about a group 4 medulloblastoma. The groups are dependent of mostly of the risk of dissemination. The group 4 have frequent metastasis and also a poor to intermediate prognosis. What is the issue with the aggressive medulloblastoma, so group 4 or group 3? Well, to answer this question, let's go through the algorithm when facing a medulloblastoma to spot any weaknesses. First, we have the diagnosis using an MRI or CT scan, and in combination with the clinical presentation, we can assess the presence of the brain tumor. After, we have to treat it. To do so, we use 3 modalities that we combine. We start with the neurosurgical tumor resection, and then we have the extensive radiotherapy, so a whole brain radiotherapy, and a chemotherapy. Unfortunately, these interventions leave noticeable sequelae, especially at the cerebral and sensory levels. We can assess these side effects during the follow-up because we will observe a multi-factor dependent survival. So besides all the physiological differences between the patients, treatment modalities have a big influence because of the secondary effects of it. We can talk about emotional ability, language and hearing deficits, concentration difficulties, ataxia, and sometimes tremors. Well, this being said, we can ask ourselves why. So far we have 2, let's say, hypotheses that may explain the outcomes. Some people will suggest the direct effects of brain lesions resulting from some surgical maneuvers, while others will talk about the known side effects of radiotherapy, such ototoxicity. However, previous studies have already identified specific regions that are more sensitive to radiation-induced atrophy, such as the hippocampus. Unfortunately, the current studies fail to provide an objective evaluation from a global anatomical perspective. This ambiguity preempts the desire to understand the complex and favorable outcomes of RT on the brain through radiation-induced atrophy. Furthermore, researchers seek to uncover the concrete effects of total radiotherapy on the brain and the long-term effects on a brain that has undergone the radiotherapy. Thus, the study of volume of cortical areas and cerebellum and thickness of subcortical areas appears to be an interesting avenue to explore, because first of all, it will allow us to identify which brain areas are more severely affected, and explain the known long-term consequences on the neurological development. And also, it will allow us to identify potential radio-oncological guidelines to reduce such unwanted short and long-term effects. And here comes AI.
That leads us to our specific aims, which are firstly, we would want to identify the specific brain regions that are more vulnerable to radiation-induced atrophy. And the second one would be simply to identify the global impact of radiation therapy on cerebral growth in a pediatric population. To achieve that, we propose two cohort studies. The first one would be treated only by surgery, and the second one would be treated by a surgery and the standard protocol with radiation therapy. It goes without saying that the distribution will be done between the two groups clinically. And chemotherapy, we put chemotherapy in parentheses because we acknowledge that it would be a confounding factors. So it would have to be treated statistically with linear regression and that sort of statistics tools. To compare the variation of volume, we propose to use firstly the diagnostic MRI and secondly the post-radiation therapy MRI, the follow-up MRI that is often done about 12 months after the beginning of radiation therapy, which is quite useful because in literature we found that most of the brain atrophy induced by radiation is noticeable. Is mainly noticeable about 6 months after the beginning of radiation therapy. So to calculate the volume of the brain and the atrophy if present, we propose to use a fast surfer, which is a deep learning pipeline that segment the brain in more than 100 subregions. And it allow to calculate the volume of all those specific subregions. So we would be able to compare the variation of volume for each of these subregions. And it also allows us to calculate the cerebral volume, the total cerebral volume, which would allow us to answer the our second specific aims.
Okay, so our first aim is to identify the brain regions that are more vulnerable to radiation-induced atrophy. So how we're going to do that, we're going to take the MRI before radiotherapy and after radiotherapy, and both of them would be statistically analyzed to identify the cerebral subregions whose volume has decreased, those regions corresponding to radiotherapy-induced atrophy. So due to the focused radiation on the posterior fossa and due to the neurotoxicity of radiation, we hypothesized that there will be a detection of atrophy mainly in the cerebellum and the brainstem. Our second aim is to identify the impact of radiotherapy on cerebral growth rate in pediatric patients. So first, we're going to take the intracranial volume of radiotherapy patients and compare them to the intracranial volume of healthy patients. Due to the frequent whole brain radiation in radiotherapy and the neurotoxicity of radiation, we hypothesized that there will be a slowdown in the development of the brain. Such a decrease could be detected by a decrease in the progression or altogether a reduction in the intracranial volume of the patients. This research has the strength of targeting the anatomopathological aspect of medulloblastoma treatment. Beyond the 3D understanding of radiotherapy impact in the brain, where we can have a dosage and a region-dependent therapy for the brain. This will allow us to potentially have a significant impact in the short and long-term quality of life of the patient. This paves the way for a more precise radiotherapy protocol in terms of dosage and targeted region, which would result to a more effective treatment with less adverse effects. So yeah, here are references, and thank you for listening to us. We're happy to answer any questions you might have.
I started last time, so I don't know, Ryan or Adriana.
Oh, hi there. It's Adriana, but I don't know if Ryan wants to start. I'm good either way.
You can start if you want.
Oh, okay. Well, yes, I just wanted to thank you for your research idea and presentation. I really enjoyed it. You're all in the MD program at Sherbrooke, is that right?
Yes.
Yeah? Oh, okay. That's great. Are you interested in radiation oncology or neuro-oncology?
I do. My colleagues here are interested in neurology and neurosurgery, so we're all about like neuroradiology.
Oh, I think that's great. I was struck by your project in that, AI, it seems to be opening up so many research avenues in medicine, particularly imaging and image segmentation. And it's also true that the use of radiation is extremely helpful to treat medulloblastoma, but it's very harmful to developing brains. So I think this idea of trying to quantify the impact of radiation on the growth rate of the cerebellum is actually quite fascinating. So I congratulate you for that idea. I don't know that it's actually been looked at, or I'm not aware that it's been looked at. So that seemed quite innovative. Certainly for very young children, we try to defer or delay it as much as possible, and use radiation techniques like proton beam therapy to avoid harming normal surrounding brain while still targeting the tumor. I was just curious because we do know that radiation is harmful to limbic structures. We know that radiation is harmful to growing brain, germinal matrix regions of the brain. So how do you think that treatment planning could be helped with this type of information your project would generate? What do you think might be different in what could be done?
Well, maybe I can take that question, but the thing is, with my limited knowledge of radiology and radiation therapy, I think it might just open the door or pave a way just to have a more, to open a way for a discussion about which treatment in which region we could just concentrate the radiation. Because with my limited exposure to radiation therapy, one of the radio oncologists here just showed me how you can literally specify in the brain or in any region with the radiation protocol, just to specify and concentrate it geographically or specifically on certain regions. So it would be interesting to maybe limit it the more the region that are more at risk of radiation atrophy. So I think it would be really like a debate about where to point the beam. So focus the beam. So
Okay, thank you.
Brian, any questions?
Just out of curiosity, do you think there's a difference when it comes to age and how like radiation affects the atrophy rate or the amount of brain atrophy? If you sort of understand what I'm trying to get at.
Yeah, we there's like there are some studies in the literature that already like talk about the effects of radiotherapy. That is, it's more marked like when the patient is under 3 years old, or I think it was really about
under 3 years old is the effect of radiotherapy is greater than over 3-year-old, and over 3-year-old it's kind of the same. They kind of group them together.
It's kind of dependent of the physiology and characteristic of each patient, which will be also a great avenue to explore. Like if with the project that we propose, we can also see if we can use machine learning to identify any like pattern between patients that are more at risk of a greater atrophy. So it's like we have space to explore more about all the specific things that will allow us to see if like a different age under than like 5 or 9 years old, for example, can be more at risk of atrophy.
You used the term deep learning. What is that?
Yeah, I can go. Well, I see it like some sort of I'm no expert in AI and all those sort of things, but I'm
see it like kind of a neural network. It's like trying to create a neural network of a human being, like the way he understands things and the way he will like analyze things by using a machine. So it's kind of like using the smart part of the machine to see the
reasoning behind the little specific things, and you're gonna have like an answer depending on the specifics.
And I just want to specify that, contrary to previous teams, we do not really propose to create a new pipeline or a new algorithm. We just use the ones that are already in use in research. So Fast Surfer is already in use. I use it in research at Sherbrooke. So we're not expert in creating AI pipeline, but we just propose to maybe use it in more clinically. So
Thank you.
Thank you.
Thank you very much.
Thank you.
This leads us to our last team, McMaster. They've got their presentation up, and we are ready whenever you are.
Thank you so much. Good afternoon, everyone. Thank you so much for the opportunity to be here. My name is Erica, and you will meet my colleagues, Patrick, Jack, and Anish soon. Our project is using an intraventricular nano device for detecting early recurrence and personalized treatment for Group 4 medulloblastoma.
Today is also National Truth and Reconciliation Day. It's a day that we want to use to recognize and commemorate the intergenerational harm that residential schools have caused to Indigenous families and communities across our country, and to honor those affected by this injustice. So in a country with a history of mistreatment to the original inhabitants of our land, we must consider how our conduct in research and healthcare can be used to build a more inclusive and unified future for all.
Thank you, Patrick. And with that, I will get into our background. Medulloblastoma is the most common pediatric brain tumor, with 30% of patients relapsing, and accounts for 10% of all childhood cancer deaths. Medulloblastoma is divided into different subgroups, with Group 4 being the most common, representing 35% of all medulloblastoma cases. Despite rigorous multimodal standard of care treatment, including surgical resection, radiation, and chemotherapy, chemotherapies such as cisplatin, which this recurrence is still observed, and patients are left with a survival rate of less than 10%. Studies have shown that the recurrent medulloblastoma mirrors the subgroup of the primary tumor.
Sorry there. Leveraging the stability of this recurrent medulloblastoma, our group decided to look into unique characteristics of recurrent Group 4 medulloblastoma, specifically the tumor that Jaden had. Essentially, what our group did is we identified the tricarboxylic acid cycle as as a dysregulated metabolic process unique to Group 4 medulloblastoma. Alpha-ketoglutarate is one of the most significantly increased metabolites in the cerebrospinal fluid of these Group 4 medulloblastoma patients. So we figured this might be an interesting angle to approach with regard to earlier detection of recurrence and to have a more targeted, directed therapeutic outcome earlier in the process. So we posit that we can develop an innovative nanodevice that will detect Group 4 medulloblastoma recurrence earlier by precisely monitoring alpha-ketoglutarate levels in the cerebrospinal fluid. This device will be integrated into an Ommaya reservoir to ensure continuous sampling of the cerebrospinal fluid in a minimally invasive manner. This nanodevice would be implanted during primary resection of the patient's tumor, and we hope that it will be less invasive than constant lumbar punctures to survey for tumor cells or having to go into the hospital consistently for conventional MRI detection methods. This Ommaya reservoir also offers a non-invasive direct avenue for targeted delivery of therapies, such as immunotherapies and CAR T cells. All in all, the earlier detection of recurrence will allow us to catch the tumor before it can grow to a significant size to allow for more proactive treatment and better patient outcomes to save the lives of children like Jaden. Now, you might be wondering, how are we going to detect this alpha-ketoglutarate and how are we going to detect this earlier detection? There have been previously validated sensitive nanodevices that detect alpha-ketoglutarate using an enzyme called glutamate dehydrogenase. So what this essentially does is it converts alpha-ketoglutarate into glutamate by using up NADH, as you can see right here. Therefore, the more alpha-ketoglutarate contained in a solution, the more NADH will be consumed. As a result of this NADH being consumed right here, there will be less electrons detected by this graphene oxide gold nanofilm covering the nanodevice. Therefore, the concentration of alpha-ketoglutarate is inversely proportional to the amount of current of NADH provided. This allows us to quantify the amount of alpha-ketoglutarate and detect it as well. So summing things up, once a certain drop in current is detected as a result of the presence of alpha-ketoglutarate, this indicates an increase in high likelihood of recurrence. Detection is then transmitted to the caregiver's mobile device, which will then monitor and send a message to the caregiving team so that they can initiate treatment early on in the process for better outcomes. So I've just discussed our first aim, Our second aim, which Jack will touch on in a second, is how we're going to preclinically validate this device for early detection in patient-derived xenograft models of group 4 medulloblastoma. And our third aim, as I mentioned, is to administer this concurrent direct immunotherapy into the cerebrospinal fluid using our entire procedure, which Jack will speak on now.
All right, great. So to ensure the efficacy and accuracy of our nano device, we will first emphasize its capability to detect alpha kg. So to do this, we will do calibration curves, which are developed using known alpha kg concentrations, establishing both the limit of detection and quantification. Next, we will prioritize consistency by conducting reproducibility tests, ensuring consistent results across multiple measurements. For in vivo validation, a more accurate methodology is implemented. After resecting the primary tumor from the patient, it's orthotopically transplanted into our animal model. Once the tumor establishes, our nano device is implanted to monitor the levels of alpha kg in real time. This approach offers a realistic simulation of the device's performance in potential clinical scenarios, highlighting its role in early detection and subsequent therapeutic intervention. So with that being said, with the recent breakthroughs in CAR T therapies for group 4 medulloblastoma, there's renewed hope for patients combating this aggressive disease. Combining our nano devices' early detection and these emerging CAR T therapies allows for a synergistic approach, ensuring patients receive the optimal interventions at the right time.
We not only aim to determine the efficacy of our device, but we aim to explore the impacts on quality of life of patients. Thus, we set out to perform cognition tests on mice implanted with this device, such as the novel object recognition test and Morris-Water maze, canonical behavior tests, which test the impacts on learning and memory. We aim to compare our device and our approach with traditional interventions for group 4 medulloblastoma, which usually consist of MRI followed by surgical resection. We posit that the use of nano device for early detection will allow for immunotherapy during a window where this is feasible. We will make comparisons between patient outcomes and quality of life measures to determine if our approach is better than the traditional intervention. We aim to deliver patient-centered care, focusing on the 3 tenets of early detection, personalized medicine, and quality of life. At the end of the day, if the tumor recurs, the battle is not over. With our nano device, we will detect the tumor earlier and initiate timely interventions, drastically improving the prognosis and offering patients like Jaden a renewed chance at a better quality of life. Thank you very much to everyone for paying attention, and the Maestro family for this opportunity, as well as the Brain Tumor Foundation of Canada.
Okay, well, I can ask a couple of questions to start. So how specific is the detection of alpha ketoglutarate? How specific, if you detect it, how specific is it to tell you that it's the recurrent medulloblastoma that's the source of it? Could there be false positives, I guess is my question.
Yeah, I can answer this question. Essentially, because of how novel this field, because of how novel the proposed nano device mechanism is, there haven't been any pre-validated specificity studies. We did, however, in our ideation for experimental validation of our device, determine specificity assays where cerebrospinal fluid of normal control patients would be compared against those of group 4 medulloblastoma patients to determine, number one, at the bottom line, whether this device is actually detecting alpha-ketoglutarate specifically, or if other metabolites within the CSF are setting it off. The second layer of this experimental procedure will allow us to determine, is this nano device, to answer your question, is this nano device detecting alpha-ketoglutarate directly from the patient's recurrent brain tumor? Or are there any other perturbed metabolic processes within the brain that could be a part of normal physiology that would detect it as well? That's a critical question that we need to answer, but it kind of comes along with the novelty of this approach that we've definitely factored into our experimental considerations. Yeah.
So I guess what I'm hearing is that if I didn't have this device, and let's say I didn't have it, and I just did a lumbar puncture on a kid, and it came back with increased alpha-ketoglutarate, I could be pretty sure that it's the medulloblastoma causing that increase, or how confident could I be? I guess that's more my question.
We selected alpha-ketoglutarate specifically. Amongst the tricarboxylic acid cycle, there were many dysregulated metabolites, but we selected alpha-ketoglutarate specifically because it was the most significantly increased within this patient cohort that these studies analyzed. So I could say with reasonable confidence.
Sensitive, but maybe not specific. And just another aspect of it, if you inject CAR T cells through the Ommaya reservoir, do they have any adverse effects on kids? Do we know that?
So there have been several trials for medulloblastoma. There have been limited trials in group 4 medulloblastoma, but CAR Ts are in the further stages of clinical trials now, and there seem to be less adverse effects, although it is important to note that at current time, there are expert labs developing more efficacious CAR Ts, which have less effects, such as like cytokine storm, which is a common hurdle that has to be defeated by the conventional CAR T approach because of the limited efficacy against solid tumors at present.
Exactly.
Thank you.
A good lab that we really enjoy is Dr. Crystal Makel's lab out of Stanford. She designs, her labs is a CAR T engineering lab where they design various intracellular signaling methods, and they have different targets that have very promising outcomes so far. But their papers are very interesting, and that's what kind of led us down that pathway as well.
Thanks. Over to Adriana and Ryan.
Yeah, great presentation, guys. I gotta say, everyone's presentation has been so organized and great graphics. I wish my presentations could be like that. But you guys have introduced a pretty interesting study. I just wonder, into the consideration of designing it, MRI compatibility and stuff like that. Would that be something that may change your design concept, or what are some things you might want to think about with that? Largely because these kids often receive many MRIs over their treatment course just to check, recurrence and stuff like that.
So I think because we're using a graphene-based device, and we're also going to model this preclinically with the mice, just the implantation of the device with the same material will determine whether there will be interference in MRI signal due to this nano device. But due to the material we have chose, we do not believe it will interfere with the MRI signal, but we would need to validate that prior. And this is a very important consideration, which we need to think about.
Exactly. And in vivo work for brain tumor or brain tumors in general, there have been MRI studies, or they do monitor tumor size via MRI. So this is definitely like a convenient experimental avenue we could pursue. And that's in addition to using luciferin-based tumors to allow for bioluminescence. So yeah, we could definitely integrate the MRI effects into our experimental procedures.
Got about 15 seconds if there's any other questions.
Oh, hi, it's Adriana here. Well, I just wanted to thank you guys and congratulate you. You're the last group to present. It's always a challenge being at the end. So thank you for sticking through right to the end and rounding out the student competition with this idea. It's pretty innovative. And I think it's quite logical as far as a biomarker, I suppose. I'm not sure about the specificity because I think alpha-ketoglutarate is pretty ubiquitous as a component of the Krebs cycle. But, detecting tumor recurrence very early, the earlier the better, I'd say, is always good. And Ommaya is a pretty static device, though. There's no CSF flow through it, actually. And so as I was reading through your letter of intent, I was kind of thinking it might be better to have your device exposed to something that has continuous CSF flow like a shunt. So it's really not a question per se, but more a comment. Or maybe you could answer the question, how would you contend with the idea that an Ommaya reservoir is just sort of sitting there? I don't know that it will, within its chamber, be continually updated for your device to detect an increase in alpha-ketoglutarate, if you know what I mean.
Yeah, I can definitely like understand your concern there. It's something that we consider as well, because Ommaya reservoirs are typically placed, the reservoirs at the surface of the scalp, and then there's a tube that enters through the lateral ventricle, which is where you're going to get your CSF fluid starting. It depends on the risks that one is willing to take during surgery, because the device could definitely be placed within, say, if you're resecting a tumor around the cerebellum, around just before the start of the central canal per se, just as a location where it would be receiving flow for CSF past the fourth ventricle. We were rather risk averse per se in our ideation for where we wanted to place this device. And we found out that there are like Ommaya reservoir taps where they sample the CSF through the Ommaya reservoir, albeit manually. So that is definitely perhaps a drawback of our posited location for this nano device. But we hope that with more knowledge about the surgical with more knowledge about surgery and the risks of placing devices in these certain areas, we would be able to place it in an area where it would ideally receive this ideal CSF flow. So definitely like a very important anatomical consideration concerning the natural flow of CSF through the ventricles and aqueducts. So yes, Dr. Rando, that was a very good point to bring up.
Thank you so much for your presentation. I really enjoyed it.
Thank you so much.
Thank you so much, everybody. That was great. It's always so wonderful to see these presentations. I appreciate the time that you've taken to present them. And now you can sit back and enjoy our next presentation. I will ask Jordan to open up the breakout session now for the judges to go into. And happy deliberating as you chat about all of these great presentations and make your selection of the top 3 teams that will be awarded. I'll give you a second there to get the room started. And in the meantime, as that occurs, I'd like to welcome Dr. Sylvia Penuela. Sylvia is our 2022 feature grant recipient. She received a $50,000 grant initially for her project entitled Inhibition of Panax-1 as a novel target for glioblastoma. And then we had a inspiration to help accelerate that project with an additional $50,000, in which has moved her through to a larger scale grant now at CIHR. So we're very excited about this and excited for her to present to us today. I just want to make sure that the breakout room is good. Jordan, are you all set? Okay, I guess they have gone. So Sylvia, I will pass it over to you.
Thank you, Sue. Thank you, everyone, and good afternoon. Thank you for the invitation and the opportunity to share some of our research here today. I know you're all anxious to hear the deliberation of the judges, so I'll try to keep your mind occupied while they do that. And I will actually switch gears a little bit to tell you about a different type of brain tumor that is the one that we focus on glioblastoma multiforme. And as Susan said, we received this very generous donation from the Brain Tumor Foundation and private donors to continue with this work. We had some ideas in the lab, and fortunately, we have been able to secure a large 5-year, $1 million grant to continue with this. So I'll show you some of the early work. I am an associate professor at Western, and I'm also the associate chair of research in the Department of Anatomy of Cell Biology, and I'm cross-appointed with oncology. So I'm a basic cell biologist. I am not a clinician, but I want to show you some of the basics of glioblastoma that maybe some of you are not that familiar with. It's a more rare brain tumor, but it has become quite prominent because of different celebrities and politicians and people that have unfortunately being patients of this terrible disease. Among them, Ted Kennedy, John McCain, Bo Biden, and then some more local Canadian ones like Gord Downey and Tom Parker. And some of these has actually inspired part of the cancer moonshot idea in the United States to try to find more options for glioblastoma. The problem with glioblastoma, of course, is like in any terrible cancer. This one is a rare one. You only have about 4 per 100,000 people in Canada has this brain tumor. But and then it's about 12 to 15% of the intracranial tumors, and 60% of the astrocytic ones. But it increases with frequency with age, and it can affect more men than women. The peak incidence is actually after 45 years of age, and it's a very rare childhood brain tumor, not like the ones you were talking about just recently. And but it just happens very fast. It can be asymptomatic for a long time, and then it reaches a large size, and the patient experiences headaches and weakness in the arms and legs, or nausea, this kind of rapid decline in memory. And it also, of course, depends on the location of the tumor. So it's a very fast glioma that rises mostly from astrocytes and oligodendrocytes, and it's considered the most aggressive primary brain tumor. It's a grade 4 astrocytoma, and the terrible part is that the median survival is only about 14 months, and this is even with treatment. So the survival rate is very, very dismal, and the treatments that normally follow are radiation and chemotherapy, but the tumor tends to come back. And so if you think about we think about the cells in the brain, we are a cell biology lab, a cancer cell biology lab. So we of course think about the neurons and the astrocytes, the oligodendrocytes, but all of them crosstalk in the brain. And if the astrocytes or oligodendrocytes start getting transformed for some unknown reason, those are the ones that would give rise to this type of tumor. They are thought so far to appear randomly or idiopathic. Some could be linked to radiation, and some to some mutations, more recently IDH and some of the other mutations, but there's no real clear risk factors. And some genetic syndromes can be also associated with GBM. And so it doesn't seem to be an inherited disease. Of course, and this is probably something that you're all pretty familiar with, a regular diagnosis is with neurological exams. There's some imaging tests that can be done, some biopsies that can be done. And normally the maximal cell-free section of the tumor is what is done for the biopsy at the same time. And so the interesting thing for us is that we normally work in other cancers like melanoma that metastasizes a lot. Glioblastoma is actually one that doesn't spread that much beyond the CNS. Those metastases, distant metastases are rare. Most of the spread happens in local metastases. And of course, it's multiform because it's many presentations, a very heterogeneous tumor. And most of the mets, like I said, will be in the CNS, rarely to the lungs or the liver. And these factors that kind of make this cancer very different, not only because of the short survival of the patients, but we also think that maybe there are other factors that are very different in these cells that make them less migratory than other cancers. Like I said, standard care is maximal safe resection, radiation. Temozolomide is the chemotherapy that is mainly used for this, but sadly, almost all of them recur. And like I said, the median survival is 14 months. So some of these reasons for treatment failure is the invasive nature of the GBM cells, the difficulty getting the drug delivery, the heterogeneity of the tumors, and then the inability to really resect them in very, very difficult parts of the CNS. So there's an urgent need for new and effective treatments for this. And some of them, like I said, have been started on the cancer moonshot in the United States. But here, we have many labs that are interested in trying to find some answers for gliomas, and in particular for GBM, or glioblastoma multiforme. And what we like to think about in our translational research at Western is what we call the triad of translational models of cancer. Start from cell culture models to animal models to human models. And that way we can make our bench basic cell biology discoveries more translational. So we have a very nice collaboration. This is the group that recently got the CIHR grant. We work with neurosurgeon, Dr. Matthew Hebb at the University Hospital, John Ronald at Robarts, who's our imaging expert, in my lab at the Schulich School of Medicine and Dentistry at Western. And what we really got interested in is these targets that we call pannexins. And pannexin channels are not very well known, but they have been shown to be making this localization at the cell surface of the cells. It can be glycosylated and modified, but they can also be expressed inside the cells and make things like calcium leak channels in the endoplasmic reticulum. We know that the topology of the protein, the kind of modifications that they do, and they can assemble into these heptamers, or 7 units that form a channel at the cell surface, or in any membrane, actually intracellularly too, and can allow the passage of large metabolites like ATP and calcium, but also many ions. And so they have different associations with many proteins that are important in cancer, like effactin, of course, for migration, beta-catenin. All of those bind directly to this pannexin-1 protein and seem to be regulating the way they function in cancer. They are low expressed in normal cells. So we see here, for example, we have control glial cells that are isolated from, these are from human samples. These normal glial cells have very low levels of pannexin-1, and all these bands that you see here are glycosylated modifications of pannexin-1. We see a lot in primary GBMs from tumors and also in established cell lines. So if we try to correlate that, we see that normal cells will have very low levels of these channel protein, but anything that is a transformed cell or either from the patient or established cell lines will have more. And they are quite intracellular in their presentation, but you can also see some at the cell surface in the different cells. So what we've been doing is trying to say, okay, but this is an interesting target, but the reason we got interested in this is because we saw that we could, for example, do a CRISPR-Cas9 deletion of this gene from these patient-derived cells, and we get some that are completely devoid of pannexin-1, and those basically stop growing. So it's almost like these cells are addicted to pannexin-1 channels, and they really need them for growth and survival. And so when you delete that, this green line at the bottom is showing the deletion, and it has completely deletion of pannexin-1. Some of the other ones are just adding different drugs that can close the channels and can block them. So we have drugs like spironolactone or probenecid that actually repurpose drugs that were used for gout or for ulcers, and for high blood pressure, actually. And so they can also slow down the growth. So we think that we can hopefully target this one. We have started moving this from the dish into more ex vivo and in vivo models. So we have chicken embryos in the lab that we can use in what we call the CHIC-CAM model, or the chicken chorioallantoic membrane model. We can do this high throughput in a way that we can put the tumor, and we can transduce these cells with luciferase so that they can actually glow in a bioluminescence assay, and we can measure the viability of these cells, the way they're growing, and we can see that tumors that are control or just vehicle have much more growth and vitality. When we add the drugs that block pannexin-1, we significantly reduce the growth of those tumors ex vivo. Of course, this is an artificial system, and we're moving into rats and mouse models now. But we can also see that in some of these assays in the chicken embryos, we can use the drugs like this probenecid that we have used to also stop the hemorrhaging of these tumors. So these tumors are very vascularized. They can do a lot of angiogenesis and also vascular leak. And we can see this in the chorioallantoic membrane, that when you have the vehicle control, you have a lot of bleeding and hemorrhaging of these tumors, but that doesn't happen when you block it with the pannexin blocker. So we're excited about preparing these data actually for publication, and we're moving, like I said, into understanding what is this channel doing, not only on the growth of the tumors, but also on the way they are affecting the vascular leak or the angiogenesis. So just to try to summarize kind of like what we think this is doing, if you think about a cell, and this in this case would be a cancer cell, these channels need to be there normally for like regular signaling, and because they release ATP, they participate in pure energy signaling. They are at low levels. In cancer cells, they are highly upregulated, so they are kind of communicating more, sending more signals of ions and also ATP. We can block these channels. We can silence some of that and reduce the tumorigenic signaling. But we can also change some things in the cell, and we have seen recently that we can change the stability of F-actin or the filamentous actin. We can also, when we block it, we can reduce beta-catenin or beta-catenin. That is a very important signaling molecule in many of these cancers. So we think that these channels are actually acting directly and indirectly through these scaffolding proteins that change the signaling. That's why they basically are addicted to these channels, and they really need them to grow, to migrate, to polymerize actin normally. And when they don't have them, they really reduce their growth, their Wnt signaling that happens through beta-catenin. And they have also, we have seen in the human tumor organoids and the rodent models that we're doing of GBM that I won't present today in the interest of time. But we have seen that also we can increase anti-tumor immune cells. And so we're hoping that we can use some of these drugs that target pannexin-1 and make new ones that are even more specific to shrink the tumors, to prevent their growth, and hopefully to increase immune infiltration when it's possible. So with that, I'll have to give credit to my team. This is my lab, and we were at a recent wedding. And these are my graduate students that work in many different aspects of pannexins in cancer cell biology, and some of the alumni that have contributed to this work. We have many collaborators that I mentioned before. We have to say thanks to the funding agencies, but in particular to the Brain Tumor Foundation that really got us going with this project and helped us really gather the important preliminary data that we needed for expanding this project. And we're very excited to be able to take this one step further and try to get it into more translational aspects of it. We are hiring, so if you know of good people that want to join our team, let me know. And these are some of my socials. If you want more information, feel free to email me. And thank you very much for your attention. I'm happy to take any questions.
Thank you so much. I think that every time I hear you present, I learn something new. So I appreciate you taking the time. And yes, does anyone have any questions? Either in the chat, or you can just put your hand up, or just take your mic off and ask.
Yeah, go ahead, Anish.
So I see you've used like the regular GBM cell lines and then I guess primary cell lines from patients. Have you looked at the levels? Does it increase in recurrence when the tumor is more invasive?
Yes, we've been trying to not only that, to try to correlate the levels of pannexin-1 to the more invasive of recurrent ones, but also to try to see if there's changes between stem cells, like cancer stem cells, and more differentiated GBMs. And in general, we do see that pannexin-1 tends to be correlated with more aggressiveness, but for really making a statement about that, we have to get the end values that we need, right? So we're doing some of that with bioinformatics as well.
Sorry, any other questions at all? Okay, perfect. All right, well, thank you so much, Sylvia, for taking the time to present. Enjoy the rest of the weekend, unless you'd like to stay and listen to the winners, but wishing you a wonderful weekend ahead. I know that you've got some commitments this afternoon, so we won't keep you. So thank you again, and we'll be in touch.
Thank you very much.
Thank you. Bye-bye. And it looks like the judges are starting to come back. We've got Adriana. Do we have? Yep, there's Ryan. Is Joe back in here? Yep, there he is. Okay, perfect.
So Ryan's gonna do the honors.
Okay, amazing. Well, thank you so much. I'm sure that it wasn't an easy task, but I will pass the mic to Ryan.
Yeah, so I thought I'd turn my camera on for this, but yeah, thank you guys for all of your wonderful presentations. It really shows how how bright the future is in terms of brain tumor research. And as you know, a lot of these families and patients are dealing with often very devastating diagnoses. So, having people to give them hope for the future and for other patients, it's absolutely wonderful and very inspiring to see. So I've been given the honor of announcing who the winners are in terms of the top 3. So I guess I will do this in reverse order, starting with third, then second, then first. So in third place, I would like to congratulate the University of Calgary team. So congratulations. In the second place, I'd like to congratulate Sherbrooke team. So awesome job, you guys. And then finally, for our first place team, I'd like to congratulate the team from Queens. So congratulations to all of our winners. You guys did an awesome job.
Thank you so much, Ryan. I know it's a big job to have, is to be the announcement of the recipient. So I think that Joe hit the nail on the head when he said before that all of you are winners. You went from 13 people to 6 today. Everyone did incredible jobs. Great work. I want to make sure that all of the teams are encouraged to join us again for future opportunities, as long as you're still available to or able to do so in terms of eligibility. I want to thank the judges for taking the time again, for helping make today a success with the case, and with all of your help in reviewing the letters of intent and making the selection of all the teams that we're going to present today. And taking the time to deliberate and make the tough decision to come up with the top 3. Want to thank anyone who is a supporter here. There seems to be lots of supporters. I apologize for any of the technical issues of people originally getting into the meeting, but I'm glad that we all got to the same spot that we needed to be. And I also wanted to thank the Del Maestro family again for making the awards possible. And also thank you to Jordan, who helped lead the breakout room so that I could focus on the speaker. So thank you so much. Absolutely amazing event. I hope that you all feel the same. And we look forward to seeing your names down the road. And if you have any questions, I'll be in touch with the winning teams, the top 3, to chat about our next steps. But in the meantime, I hope everyone enjoys the rest of their weekend and the rest of the day. Anything at all from the judges that you had?
Thank you to you, Sue, for organizing this. I'm just looking at my cat lying in the sun, and I think your job is like herding cats. Between the participants, the judges, the infrastructure people, it's very hard to pull it all together. So thank you for keeping everybody on track and making the event happen. I do sometimes miss things in person, especially the teams that end up getting prizes, jumping up and down and cheering, but I'm imagining it in my brain as I look at every name here across the Zoom page here. But no, thanks, Sue, for organizing it all.
Thank you, Joe. Excellent. Well, without further ado, we will let everyone carry on with their day. And thank you so much for your involvement.